Good afternoon, respected faculty and dear colleagues. I'm Dr. Shivam, Senior Resident in Department of Neurology, AIIMS, New Delhi, and I'm going to present the clinical combined rounds for today, titled Unraveling the Complexity of Brain Infection. So we are discussing case of Mrs. P, who is a 47-year-old female homemaker, right-handed individual. For better understanding, we have divided the course in three parts. One is the pre-admission part, starting from May 2023 to December 2023. She was admitted with us in December 23 until January 24, and we are following up until very last week. So this patient presented to us with chief complaints of recurrent episodes of focal clonic movements of right upper limb and lower limb, followed by transient weakness of right upper and lower limb since past 8 months, starting in May 2023. Patient was apparently asymptomatic until 8 months back. She had 2 episodes in May and June 2023 of right-sided upper and lower limb focal motor seizures, lasting for about 2 to 3 minutes. There was no associated impaired awareness. There was no associated involuntary maturation or tongue bite. Following this, patient had transient right upper and lower limb weakness, and this used to spontaneously resolve in about 2 to 3 hours. She had third similar episode in end of August 2023, wherein she had similar right-sided upper and lower limb focal motor seizures, but this time it was followed by persistent right-sided weakness in the form that she has reduced right-sided hand grip, and also there was slippage of chupples from right lower limb. There was no complaints of any constitutional symptoms like recurrent fever, night sweats, weight loss, or appetite loss. There was no complaints of any headache or loss of consciousness. There was no symptoms to suggest any cranial nerve involvement. There was no complaints of any numbness or paresthesias, and there was no complaints of any swaying while walking. If you look at her past history, patient was on thyroxine 100 microgram supplement for hypothyroidism, which she was diagnosed 1 year back. Besides this, in April 2022, she has presented to AIIMS surgery department with a painless right-sided neck swelling for 3 months. She was investigated further by surgery department, wherein they did an ultrasound and they found that the right lobe of thyroid was enlarged and it was thyroid 4. And there was also multiple supraclavicular as well as cervical lymph nodes level 5, the largest being around 1.8 centimeter. So the patient underwent a lymph node FNAC, which showed necrosis, but there was no acid-fast bacilli seen. And at the same time, she underwent a FNAC of the thyroid swelling, which showed benign follicular cells and cytology was negative. We'll be discussing these slides later. So after this, she was advised a follow-up in medicine department, but the patient was lost to follow-up. So if you look now, the patient has presented to us with the above complaints, and her first visit was in AIIMS casualty at around 5th of September, wherein when she had persistent right-sided weakness. And at this time, we got an MRI imaging done from emergency itself, and she was diagnosed based on the imaging to have a tubercular brain abscess. We'll be discussing the imaging subsequently. But at this point, patient was started on a weight-based anti-tubercular therapy, including isoniazid, rifampicin, pyrazinamide, and streptomycin, along with dexamethasone 0.4 milligram per kg and levetiracetam. At this point itself, patient was advised admission and evaluation for a neurosurgical intervention, but the patients and relatives were relatively reluctant, and they were persistent on an OPD follow-up. So patient was followed up on an outpatient basis. So if you look at this, she followed up after 4 weeks. She reported 80% improvement in her weakness with no new seizures, and patient steroid doses were started to be tapered by 2 milligram per week after 6 weeks of full dose. And if you look after in November, when the dose was tapered to 6 milligram per day from 24 milligram, patient now reported worsening in her weakness. And also we had to increase the dose. We doubled the dose to 12 milligram per day, after which she again reported symptomatic improvement. So this was clear that patient was having a clinically waxing and a waning course. And in December 2023, when again the steroid doses were tried to be tapered, she again presented with right-sided focal seizures. So definitely there was clinical worsening was going on, and most of the symptoms are mostly steroid responsive. So this was the pre-admission part we discussed. Now she was admitted to us in December 2023, and we'll be discussing that. So if you look, when she was admitted at this time in December, she was moderately built and well nourished. There was pallor was present. There was no clinically palpable lymph nodes. On CNS examination, her higher mental functions and cranial nerves are normal. But on motor examination, there was grade 1 spasticity in right upper and lower limb with a power of nearly 4 by 5 on the right side, with brisk reflexes on the right side and extensor plantar. Other sensory cerebellar examination was normal. Meningeal signs were absent. So if you analyze the symptoms now, she was having right-sided focal motor seizures with intact awareness, followed by Todd's palsy. And then she developed persistent right-sided weakness, which was right hemiparesis. All of these localized to left motor and supplementary motor cortex. So these were the differential diagnoses, obviously, when we look that were considered in with the clinical symptoms she was having. Mostly some lesions in the left motor cortex, including infectious tuberculoma or NCC, gliomas, abscess, tubercular, bacterial, fungal, demyelinating lesions, and inflammatory pathologies. So on initial lab investigation, if we see, she was having some microcytic anemia, and her baseline LFTs, if you look, they were slightly elevated, but less than 2 times the upper limit of normal. So first one is before starting anti-tubercular therapy, and second one is 3 months into the anti-tubercular therapy, where the LFTs are almost nearly the same, less than 2 times the upper limit of normal. We also worked up for anemia, and she had a low ferritin with the other parameters almost near normal. And this was a workup for immunodeficiency, which it did. Her HIV ELISA was negative, immunoglobulin levels were normal. She had some HbA1c around 6.1, that was some impaired glucose tolerance range, but her fasting and postprandial sugars in the ward stay were normal. And her ESR also was slightly elevated, 30 mm per hour. So I would now like to invite Dr. Tanya from Department of Neuroradiology to discuss the MRI findings.
Good afternoon, everyone. So this was the first MRI scan that was done at the time of diagnosis, which showed a single lesion in the bifrontal region involving the dura, which was hypointense on T2 weighted images, hypointense also on T1 weighted images, did not show any blooming on SWI, suggesting hemorrhage or calcifications. A small part of the lesion on the left side showed restriction on diffusion weighted images, and on post-contrast images, the lesion showed peripheral irregular nodular enhancement, and these are the representative coronal T2 and T1 weighted images. There was also edema in both the frontal lobes, more on the left side. Subsequently, perfusion scan and MRS was also done on the lesion. Perfusion images did not show any raised perfusion within the center. Small increase in perfusion in the rim of the lesion was seen. On MRS, there was a prominent lipid peak. So a provisional diagnosis of tuberculoma with abscess formation was made. Chest X-ray did not reveal any pulmonary infiltrates. Subsequently, 3 months following ATT because of non-resolution of clinical symptoms, CCT and subsequently MRI of the patient were again performed, and this is the CCT scan which was done in early December, which showed increase in the size of the lesion and increase in edema in the left frontal region. These are the representative images of MRI, which again showed increase in the size of the lesion. There was increase in T2 hyperintense component of the lesion with increase in perilesional edema in the left frontal lobe. The morphology of the lesion had not changed. It still appeared hypointense on T1 weighted images, no evidence of hemorrhage or calcifications on SWI. There was an increase in the component of diffusion restriction in the lesion, suggesting increase in abscess formation, peripheral nodular enhancement, and no increase in perfusion. So provisionally, this appears to be an abscess, and this is just a review of the 3 common etiologies of brain abscesses, which I have put up here, images I have taken from literature. So the tubercular abscesses will show a smooth or an irregular nodular rim with diffusion restriction in the center and a prominent lipid peak. In pyogenic abscesses, the wall of the abscess is smooth and shows central diffusion restriction. And on MRS, there are prominent, apart from lipid and lactate peaks, there are multiple amino acid peaks between 1 and 2 ppm in pyogenic abscesses. The morphology of fungal abscesses radiologically appears to be slightly different from tubercular and pyogenic, with the fungal abscesses showing a crenulated irregular rim enhancement. There is appearance of multiple fungal hyphae or debris within the lesion. These intracavity projections appear hypointense on T2 and show diffusion restriction, whereas the rim whereas enhancement is only seen in the rim of the lesion, whereas the projections do not show any enhancement. Apart from prominent lactate and amino acid peaks in fungal abscesses, a Peak specific for fungal abscesses would be of trehalose, which is seen at 3.8 ppm on the short TE-MRS. So, based on these features and review of literature, with the lesion being hypointense on T2 images in the initial phase, showing rim enhancement and central diffusion restriction, absence of hemorrhage, absence of intracavitary projections, and a prominent lipid peak, radiologically, the lesion appears to be of tubercular etiology. So, radiologically, the diagnosis was tuberculoma with tubercular abscess.
So as we see, there was clinical deterioration from her course, and on radiology also there was increase in size of the lesion with radiological worsening. So a shared decision was taken with the relatives, and they finally agreed on an excision of the abscess. I would like to invite Dr. Saurabh from Department of Neurosurgery to discuss the neurosurgical course.
Good afternoon, respected faculties. I will be describing the surgical aspect of this patient. So, patient was taken into operating room on 1st of January this month. Our plan was to do a left-sided parietal craniotomy, and based upon intraoperative finding, we decided to proceed with the decision of either aspiration or excision of abscess. So, intraoperatively, we found that the lesion was very thick-walled and the content were non-aspirable, and it had a clear plane from the surrounding brain parenchyma. So, excision of brain abscess was done. However, towards the end of surgery, we noted that there was a brain bulge. So a decision of not putting bone flap was taken, and again incision was closed in layer, and patient was shifted to ICU. And in the ICU, we found out that patient had right side hemiplegia, although she had reverted to E4VTM6. So we did an early post-op NCT scan to look for any intraoperative changes, and we found out there was a venous infarct with mass effect and midline sepт. So immediate decision to take this patient to OR and do a left-sided frontotemporal parietal decompressive craniotomy was taken. Intraoperatively, we found out that the dura was very tense after craniotomy, and C-shaped durotomy based upon sphenoides was done. And you can see that the brain was hyperemic. In this portion, you can see this was the cavity which was excised, and this is being the frontal pole and the temporal pole. After this, watertight lax duroplasty was done with peritoneum flap, and again, patient was shifted to ICU. This is the post-op CT scan showing adequate decompression and after removal of bone flap, and there is somehow resolution of mass effect and midline sepт. Patient then reversed to E4VTM6, subsequently extubated after 2 or 3 days. Medical management of anti-edema measures were continued. At this point of time, she continued to have right hemiplegia, which will be described later.
Thank you, Dr. Saurabh. So, as we see, she underwent the excision of the abscess, but post that she developed a venous hemorrhage. So we had started the patient on the same on anti-edema measures beside the decompression hemipenectomy which she underwent. Also, she was transfused packed red cells and hematinics were continued, and steroids and anti-tubular therapy were continued. So the very next day after the excision of the abscess, the first call we received was from microbiology department that some spatial stains have flagged. So I would like to now invite Dr. Neha to just discuss the microbiology findings.
Good afternoon all. So I'll discuss the microbiological findings. Okay. So we received the pus sample in TB lab and we performed all the investigation in accordance with the WHO guidelines. So the first investigation is the Zeal-Nielsen staining, that is the Zn staining. In this case, we found acid-fast bacilli, as you can see here. These are the thin, slender, beaded appearance, and they're sometimes present in the clumps. And in this case, the staging was 3+. That is, it has more than 10 bacilli per oil immersion field. So the next investigation we performed is the Gene Expert MTB-RIF assay. So we can see these are the CT values of the probes. In this case, we detected it with a medium load, and rifampicin resistance was not detected. We also performed the MIGIT 960 liquid culture media, that is the liquid culture investigation of this, and we saw that after 7 weeks of incubation, it was negative. That is, this is the growth threshold line, and this is the graph of the sample. So had it been positive, this graph would have crossed it within the 7-week incubation time. So we also performed the PCR of the sample. So here we can see that the PCR of the sample was actually positive. So this is the ladder and this is the positive control. That is the sample of a known positive patient. And this is our test sample, this patient. And this is the negative control, which is showing no band. So this test was valid. And this PCR, we detect the MPT64 gene. That gene is specific for the MTB complex group. I'll just summarize the findings here of the TB lab. So that in stain, as we saw, it was positive. AFB was seen with a load of 3+. The gene expert finding was again positive. It was detected with a medium load, but the rifampicin resistance was not detected. So PCR was positive and the midget liquid culture was negative. So as we saw here, the microscopy findings and the molecular tests are coming positive, but the culture report is actually negative. So this could be due to the presence of non-cultivable bacilli or the presence of VBNC, that is viable but non-culturable bacilli, most likely due to the drug pressure, because this patient had already been started on ATT. So we need to keep in mind that the pus needs to be entirely removed for adequate response. Also, the completion of the entire ATT is very crucial, and then the extra pulmonary sites also need to be monitored for complete response. So coming to the fungal lab investigations, so here we are performing the KOH staining. The sample is brain biopsy. And here we performed the calcophore white staining. The stain used is calcophore white, which is a fluorescent stain. It binds with the fungal cell wall. And if we see the sample in a fluorescent microscope in a certain wavelength, it will fluoresce. So here we can see this and this. So this is a septate hyphae. So we can see the branching here. It is having a typical dichotomous branching with some septa visible, and this is acute angle branching, this case. So we have reported this as septate hyphae found. So we also performed the PCR of the sample. The pan-fungal PCR of the sample came positive, and then we performed a genus-specific PCR, which was also positive for Aspergillus genus. So for the microbiology, we have performed these many investigations, and now I'll request Dr. Charlie to discuss the histopath.
Good afternoon, everyone. I will be discussing the pathological findings. So we received 3 samples in total. In 2022, we received FNSE from right lobe of thyroid, which shows few benign follicular cells entrapped in blood clot in the background of thin colloid. So diagnosis of benign follicular nodule, Bethesda category 2 was given. The second sample was again FNSE from lymph node, which showed predominantly necrotic tissue, and the AFB was negative. The next sample we received in 2024, which was of a brain abscess. This is the low power of view of the biopsy. Here we can see that there is reactive gliosis and dense mixed inflammatory infiltrate. The mixed inflammatory infiltrate was made up of lymphocytes, plasma cells, and neutrophils. There were sheets of macrophages, foamy macrophages also, with extensive areas of necrosis. Spatial stains for fungal profile and acid-fast bacilli were negative, and IHC immunohistochemistry for toxoplasma was also negative. So the diagnosis of organizing abscess was given.
So just to sum up the investigations which we saw until now from the microbiology and the neuropath. So the gene expert aspirate as well as the gene expert poll was positive for MTB. The TB PCR was positive. ZN stain showed 3+ AFBs. KOH mount showed thin septate hyphae, and pan fungal PCR, which we got eventually, was positive for Aspergillus. So her final diagnosis now which we consider was a tuberculous and Aspergillus brain abscess in the setting of a microcytic hyperchromic anemia with hypothyroidism. So looking at the therapy, she was already on anti-tubercular therapy, and after the KOH stain, we have started her on a broad spectrum antifungal, which was liposomal amphotericin B. But as soon as the diagnosis was pinned to Aspergillus, we have changed it to voriconazole. This was during the admission 8-day post excision of the abscess, wherein she has developed a drug-induced liver injury, as we see here. ASTs and ALTs are elevated. So she was started on a hepatosafe anti-tubercular therapy right now anyway, because with voriconazole, anyway, rifampicin can't be given. So she was switched on to a hepatosafe anti-tubercular therapy. Also, we have done a PET scan of the patient to look for any other site of focus of abscess or infection. So I would like to invite Dr. Aparna to discuss the PET findings.
Good afternoon, everyone. The patient was referred to nuclear medicine department to look for any other active sites of infection. So the FDG PET CT was done on 18th January 2024. This is the maximum intensity projection image showing physiological FDG distribution and reactive bone marrow uptake in the axial skeleton and no other site of abnormal uptake. Then the axial CT and fused PET CT image showing hyperdense lesion in the left parasagittal location, likely post-interventional changes. Then bilateral mild pleural effusion. Then lytic lesion with sclerotic rim on the manubrium with no FDG uptake. Then other sites of lymph nodes with no significant FDG uptake. These findings suggest that the patient has already receiving anti-tubercular therapy, maybe responded to that therapy, but there is no baseline PET CT for the comparison. So we conclude that currently no active site of infection in the body.
So we have seen the pre-admission and the current admission course. Now we'll see the follow-up. So she has followed up last and during the last week itself. So she is 2 months post excision of the abscess. There has been no seizure recurrence. The hemiplegia which she developed is improving. However, she has developed a increase in right-sided head swelling post excision, which is actually a CSF hygroma, and the patient is conservatively managed in accordance with the neurosurgery department. So these are the follow-up lab investigations. As we saw, she has developed a drug-induced liver injury, but now the ASTs and ALTs have normalized, and we have started reintroducing the first-line anti-tubercular therapies. The follow-up plan is to continue the anti-tubercular therapy for 12 months and to continue the antifungal therapy for 12 weeks. So some discussion about brain abscess. So it's as you know, brain abscess is a focal collection of pus in the brain parenchyma surrounded by a well-vascularized collagenous capsule. Annual incidence has been estimated at 0.4 to 1.3 per 1 lakh inhabitants. If you look at the literature of a co-infection with tuberculosis and aspergillus in the brain, we find just a few case reports and some case series as we see here. This was the case series from AIIMS Jodhpur published recently as an abstract, where we see they have screened 57 patients with TB and some other risk factors. They were evaluated for invasive aspergillosis, and 5 patients were found to have a concomitant infection, 3 of which was having a concomitant CNS infection and 2 of concomitant pulmonary infection. 3 of them were treated with amphotericin and 2 with voriconazole, out of which 4 survived and 1 died. And there's one other case report of a 5-year-old girl who was treated with tuberculosis with hydrocephalus. She had a VP catheter in situ, which was removed and showed the growth of Aspergillus fumigatus. Eventually, she succumbed to the illness. And this third case report of a 33-year-old male, he's a post-renal transplant recipient on immunosuppressive drugs. And patient has presented with multiple ring-enhancing lesions, and PCR was positive for both tuberculosis and Aspergillus. Unfortunately, this patient also succumbed. So if you see, there are only few case reports and the mortality rate is quite high. But in our patient, we are managing. So I would like Dr. Jayashree to discuss brain abscesses from infectious disease perspective.
Good afternoon, everyone. So the main question we had with respect to this patient was why would she deteriorate after starting therapy? So the ATT was started on September. The patient did well for 2 months and then she started deteriorating. So what all factors to consider when a patient starts deteriorating on ATT? So first will be the patient-related factors. We have to ensure that the patient is compliant to the treatment and the dosing is adequate and ATT is to be taken correctly on an empty stomach. And the patient should not have any uncontrolled comorbidities like diabetes. And one of the most important factors that we need to focus is the nutrition of the patient. And the other factors are the disease-related factors. We should try to get a microbiological diagnosis in all cases of TB suspects because there's a possibility of drug-resistant TB and TB iris, that is TB immune reconstitution inflammatory syndrome. And we have to rule out other coexisting infections or look for an alternative diagnosis. And the therapy-related factor are the drug-related liver injury and drug interactions. So, in the recently published WHO handbook for the year 2023, it was seen that in India, less than 20% of the people who were diagnosed with TB were initially tested with a WHO recommended diagnostic test, and which is very less. So we have to try to get a microbiological diagnosis. And now moving on to the next possibility, TB iris. We are all familiar with the concept of iris in HIV infected patients, but it can occur in HIV infected as well as non-HIV infected patients. It's just an abnormal immune response to the mycobacteria. The incidence of TB iris in HIV non-infected patients is around 2%. And the median time to onset of the paradoxical response was 21 to 56 days after initiation of ATT, which coincides with our patient. But before confirming the diagnosis of iris, we have to rule out other possible causes of deterioration. In our case, the patient had a co-infection with Aspergillus. She also had a fungal brain abscess, so that was the reason for deterioration. And now, since she developed DILI, we had to think of liver-safe ATT regimen, levofloxacin, linezolid, ethambutol, amikacin, streptomycin. And now another problem we had with the patient was administrating voriconazole for the Aspergillus, but again, she was also on ATT, and voriconazole rifampicin interaction was a therapeutic conundrum for us. Voriconazole is actually a substrate and inhibitor of the cytochrome enzymes, whereas rifampicin is a cytochrome inducer. So if we give both of these drugs together, rifampicin will cause voricanazole's maximum concentration to decrease by 99%. So these drugs are contraindicated for co-administration. Carbamazepine, rifampicin, rifabutin, and as well as rifampicin should not be given along with voriconazole. So the final take-home message that we would like to convey is that we should always try to get a microbiological diagnosis in all patients suspected to have tuberculosis, and focus on the patient factors. Look at the patient first, focus on the nutrition and compliance of the patient. And TB iris is a possible differential in non-HIV infected patients as well. Voriconazole has good CNS penetration, but it is not to be given with rifampicin, rifapentin, and rifabutin. And surgical management is has a key role to play in the management of brain abscess. So we would like to acknowledge the departments involved in the management of these cases. And thank you.
So I'd like to thank everyone who participated in any way towards contributing to the diagnosis and management and successful outcome of the patient. We put up this case in CCR because usually tuberculosis CNS is something which we treat day in and day out. However, in a few challenging cases where we walk that extra mile in order to go and get a molecular diagnosis, sometimes we land up in more dilemmas. Like this patient had associated fungal infection also, and we would not have discovered till the time we had not traveled that distance. So there are still some open questions because patient is still on follow-up. So any questions from anybody would be welcome. And I would like to thank Shivam for putting up all the work and coordinating with everyone, and Dr. Jasmine also for coordinating all the departments.
Is there any post-op investigation, MRI or contrast scan to see whether the lesion has responded? It is there, but it is non-contrast, so we cannot say whether they have responded or not for the treatment.
So the earliest thing is actually a clinical resolution. So once the patient's symptoms are subsiding, and obviously she had a post-operative complication. A lot of times the patients themselves defer, and the surgeons are also a little hesitant in doing a biopsy from which is bang on the motor side, because she did develop a hemiplegia. And after doing a brain abscess drainage, we were actually contemplating whether we did the right thing, or if it was tuberculosis in the first place, we could have even left it and given a more aggressive treatment, or maybe added second-line anti-tubercular treatment. This patient was also not agreeing for a biopsy initially till the time she started deteriorating herself, and we gave her the option of either escalating steroids and challenging, and also leaving it open that if it is some other fungal infection, it might even flare up. That was the time when the patient consented for a biopsy. So, like the infectious disease counterpart said that we should get molecular diagnosis in each and every person. When it comes to central nervous system, it's difficult and it's very challenging. Any other comments?
How frequently it has been reported as in immunocompetent patient that aspergilloma infection?
So fungal in ISO, if you look at co-infections, we have just few case reports, and the one I presented, the most of them were immunocompetent. And if you look at the fungal infection as such, nearly 40 to 50% in various case series have shown that the fungal infection are seen in immunocompetent individuals. Tuberculosis, majority are seen in immunocompetent. Fungal, nearly 40 to 50% are seen in immunocompetent.
In CNS, we just found 2 cases in the series of the reports that we presented. Around 12 months we plan for ATT, and for that we also want to see the imaging, serial imaging. For fungus, we want to continue the treatment for at least 12 weeks.
Can I just add, the regimen prescribed for neurological TB is the same as pulmonary regimen. So we did a study with Dr. Achal, who's here. It was a DM infectious disease thesis where we showed that a substantial number of the patients given the first line were not having adequate levels in the CSF, meaning thereby the MIC, which is essentially required, ideally we treat with dosages that reach at least 4 times the MIC levels in the blood. So the CSF levels, the only drug that did reach above the MIC was AIIMS. The rest, the first line, rifampicin, ethambutol, pyrazinamide. Pyrazinamide is known to be
Good CNS penetration.
So the bottom line I'm trying to say is we are trying to treat a cavity which doesn't always get the due amount of the drugs we're using. So ideal would be, and in fact that is what we're trying to push when we've communicated this paper, that we should have a regimen which is actually designed for TB meningitis with drugs which get to penetrate and achieve, also not only achieve, initially when the blood-brain barrier is not effective because of the inflammation, the drugs do reach, but within a few weeks, the blood-brain barrier becomes active again, and these drugs do not maintain the levels. So whether you treat them with RHE, I'm just saying in the case there is no complication, even those do not maintain good drug levels after the blood-brain barrier is closed. So we need to push for, in fact, who's better than neurologists to actually suggest to push for better regimens which are designed for TB meningitis or CNS TB and not use pulmonary TB regimens. Even if you use longer, you may be pushing the patient towards MDR because this is a known fact. If you provide less amount of drug, the organism tends to accumulate resistance. So this is something where we are actually enhancing resistance. Secondly, Dr. Shivam pointed about TB and Aspergillus, and Dr. Gagan is here, and there are studies where in pulmonary, a lot of co-infections have been demonstrated. Of course, I think this study must be under communication. This is one study is under communication led by Dr. Animesh Reyes, I think, from medicine.
Thank you, ma'am, for that very useful inputs. And actually, abscess is an attempt of the body to wall off. Yeah.
The ID resident presented a paper which I beg to differ. The molecular methods are much more widely available, especially with National TB Elimination Program. They're much more widely available. So 20% somebody may not have actually looked up the. So I beg to differ there. It's widely available now. But of course, your reasons that CNS and CSF samples are difficult to acquire, and once a tuberculoma forms, then of course neither will the treatment go in, nor will the DNA. Yes. Sometimes in tuberculoma patients, we are not able to pick up DNA from the CSF also. There is so much of a walling off because of the fibrosis.
Thank you, ma'am. I don't want to encroach on the other department's time, so we'll go on to the next.